Welcome to EMT Essentials by Bilal. In this session, we'll take an in-depth look at a life-threatening emergency, stroke, medically known as a cerebrovascular accident or CVA. This presentation covers its pathophysiology, diagnostic process, emergency management, and treatment protocols designed specifically for healthcare professionals and emergency care providers. A stroke is a sudden neurological deficit resulting from an interruption in the brain's blood supply. It is a true medical emergency that can lead to permanent disability or death if not recognized and treated promptly. Strokes are broadly classified into three types. First, ischemic stroke, accounting for nearly 87% of all cases, caused by a blockage in a cerebral artery, either due to a local clot or an embolus. Second, hemorrhagic stroke, which makes up around 13% of cases, occurs when a blood vessel ruptures, leading to bleeding within or around the brain. And third, the transient ischemic attack, or TIA, often called a mini-stroke, is a temporary episode of neurological dysfunction without permanent damage, but it serves as a warning sign for future strokes. Let's understand the underlying pathophysiology of stroke. In an ischemic stroke, the blood flow to a part of the brain is obstructed, most commonly by a thrombus forming at the site of an atherosclerotic plaque or an embolus traveling from the heart or other arteries. This blockage deprives brain tissue of oxygen and glucose, leading to a cascade of cellular injury, inflammation, and eventually, neuronal death. The surrounding zone of at-risk tissue is known as the penumbra, which is salvageable if treated in time. In contrast, a hemorrhagic stroke results from the rupture of a cerebral blood vessel, leading to bleeding directly into the brain tissue or surrounding spaces. This causes a mass effect, increased intracranial pressure, and toxic effects from blood breakdown products, all of which accelerate brain damage. Understanding this difference is essential for selecting the correct and timely treatment strategy. Identifying risk factors is key to both preventing strokes and managing patients who are at risk. There are two main categories: modifiable and non-modifiable factors. Modifiable risk factors include hypertension, the most significant contributor to both ischemic and hemorrhagic strokes; diabetes mellitus; atrial fibrillation, which increases embolic risk; hyperlipidemia; cigarette smoking; obesity, and a sedentary lifestyle. Excessive alcohol use and uncontrolled stress also play a role. On the other hand, non-modifiable risk factors include advanced age, male gender, family history of stroke, and certain ethnicities, particularly South Asian and African populations, who have a higher risk profile. Managing these risk factors is vital in stroke prevention and long-term patient care. Recognizing the clinical signs of stroke quickly can save brain function and lives. The most widely used tool is the fast mnemonic: F for face drooping, A for arm weakness, S for speech difficulty, and T for time to call emergency services immediately. But in clinical settings, stroke symptoms can go beyond fast. Patients may also present with sudden confusion or disorientation, visual disturbances like blurred or double vision, loss of coordination or balance, severe headache, especially in hemorrhagic stroke, and nausea or vomiting. In posterior circulation strokes, symptoms may include vertigo, ataxia, or even coma. Early identification of these signs is crucial for timely imaging and intervention. Once stroke is suspected, rapid and systematic neurological assessment is critical to determine severity and guide treatment. The most widely used tool in clinical practice is the NIH Stroke Scale, or NIHSS. This 15-item scale evaluates multiple neurological functions, including level of consciousness, gaze and visual fields, facial palsy, motor strength in arms and legs, limb ataxia, sensory loss, language function, and neglect. The score ranges from 0 to 42. A score of 1 to 4 indicates a minor stroke. 5 to 15 is moderate. 16 to 20 is moderately severe, and above 20 suggests a severe stroke. The NIHSS not only helps in assessing baseline deficit, but also monitors progress and predicts outcomes. In suspected posterior circulation strokes, the FAST Plus or expanded assessments are needed to capture symptoms like dysphagia, diplopia, and truncal ataxia. When managing a suspected stroke in the pre-hospital setting, every minute counts. The goal is to preserve brain tissue and prepare the patient for rapid intervention. First, ensure the patient's airway is clear and assess breathing and circulation, the ABCs of emergency care. Administer supplemental oxygen if the oxygen saturation is below 94%. Position the patient with the head elevated at 30 degrees to help reduce intracranial pressure. Check blood glucose levels immediately. Both hypoglycemia and hyperglycemia can mimic stroke symptoms. Do not allow the patient to take anything orally, as their swallowing ability may be compromised. Establish at least one large bore fall line and begin monitoring vitals. Document the exact time the patient was last known well. This is critical for determining eligibility for thrombolytic therapy. Finally, ensure rapid transport to a designated stroke center, preferably one with advanced imaging and interventional capabilities. Remember, time is brain. Delays in pre-hospital care can cost millions of neurons per minute. Once the patient arrives at the hospital, a rapid and focused diagnostic workup is essential to confirm the stroke type and initiate treatment. The first priority is neuroimaging. A non-contrast CT scan of the head must be performed immediately to rule out hemorrhage. If ischemic stroke is suspected and the CT is negative for bleeding, proceed with CT angiography to assess for large vessel occlusion, or consider MRI with diffusion-weighted imaging if available, which is highly sensitive for early ischemic changes. While imaging is underway, order essential labs, including blood glucose, CBC, coagulation profile, PT, INR, APTT, renal function, lipid panel, and cardiac enzymes, especially if the stroke may be cardioembolic. Also perform an ECG to assess for arrhythmias like atrial fibrillation. The goal is to complete imaging and labs within 20 to 30 minutes of arrival, so that definitive treatment, like thrombolysis or thrombectomy, can begin within the critical therapeutic window. Management of ischemic stroke focuses on restoring blood flow to salvageable brain tissue, primarily the ischemic penumbra. The cornerstone of treatment is intravenous thrombolysis with alteplase, also known as TPA. It must be administered within 4.5 hours of symptom onset. The dose is 0.9 mg per kilogram, with a maximum of 90 mg. 10% is given as an initial for bolus over 1 minute. The remaining 90% is infused over 60 minutes. Strict criteria must be followed before administration, including blood pressure control, exclusion of bleeding risk, and confirmation of ischemic stroke on imaging. Patients with large vessel occlusion, such as in the internal carotid or proximal middle cerebral artery, may be eligible for mechanical thrombectomy, which can be performed up to 24 hours from symptom onset based on advanced imaging criteria. Additionally, antiplatelet therapy with aspirin, usually started 24 hours after TPA, is essential for secondary prevention. In some cases, dual antiplatelet therapy with clopidogrel may be initiated for short-term use. Management also includes statin therapy, strict blood pressure control, and addressing underlying causes such as atrial fibrillation or carotid stenosis. In hemorrhagic stroke, management revolves around controlling bleeding, reducing intracranial pressure, and preventing secondary injury. The first priority is blood pressure control. Target a systolic blood pressure below 140 mm of mercury using agents like labetalol or nicardipine. This helps limit hematoma expansion while maintaining cerebral perfusion. If the patient is on anticoagulants, reversal is critical. For warfarin, give vitamin K along with prothrombin complex concentrate or fresh frozen plasma. For direct oral anticoagulants, use specific reversal agents like idarucizumab for dabigatran or andexanet alpha for factor XAR inhibitors. In cases of increased intracranial pressure, administer mannitol or hypertonic saline to reduce cerebral edema. Elevating the head of the bed and ensuring adequate ventilation also help. Seizure prophylaxis with drugs like levetiracetam may be considered, especially in lobar hemorrhages or with clinical seizures. Surgical options include craniotomy for hematoma evacuation, ventricular drain placement for hydrocephalus, or aneurysm clipping or coiling in subarachnoid hemorrhage. Early neurosurgical consultation is essential. Overall, hemorrhagic stroke requires close ICU-level monitoring, rapid interventions, and a multidisciplinary approach. Let's now review the key medications and doses used in stroke management, starting with ischemic stroke. The most critical is alteplase, or TPA, dosed at 0.9 mg per kilogram, with a maximum of 90 mg. Administer 10% as a bolus over 1 minute. The remaining 90% over the next 60 minutes. After 24 hours, if there's no evidence of bleeding, start aspirin at 160 to 325 mg orally once daily. For certain high-risk patients, clopidogrel may be added, with a 300 mg loading dose, followed by 75 mg daily. For long-term stroke prevention, prescribe atorvastatin, typically 40 to 80 mg daily, especially in patients with atherosclerotic disease. Blood pressure should also be tightly controlled. For options include labetalol, 10 to 20 mg for every 10 minutes as needed, or nicardipine, started at 5 mg per hour and titrated based on response. Now for hemorrhagic stroke. To manage intracranial pressure, use mannitol at 0.25 to 1 gram per kilogram for every 6 to 8 hours, or hypertonic saline if mannitol is contraindicated. Levetiracetam, 500 to 1000 mg twice daily, may be used for seizure prophylaxis. Remember, exact doses should be adjusted for patient-specific factors, including renal function, age, and concurrent medications. Always monitor closely for side effects and therapeutic response. Once stabilized, stroke patients require close observation in a stroke unit or intensive care setting. Initial monitoring priorities include continuous ECG for arrhythmias, pulse oximetry, targeting oxygen saturation above 94%, frequent neurological assessments using tools like the NIHSS stroke scale. Maintain systolic blood pressure below 185 mm of mercury for thrombolysis candidates, but avoid lowering it aggressively in the acute ischemic stroke setting unless it exceeds 220 to 120 mmHg. Monitor blood glucose and keep it between 140 to 180 mg dl. Start DVT prophylaxis within 24 to 48 hours, using intermittent pneumatic compression initially, then low molecular weight heparin once bleeding is excluded. For patients with dysphagia, assess with a swallow screen before allowing oral intake. If needed, use nasogastric feeding to prevent aspiration. Supportive care includes maintaining normothermia, preventing infections, early mobilization, and rehabilitation planning. Multidisciplinary involvement is key, involving neurology, physiotherapy, speech therapy, nursing, and nutrition. Regular brain imaging, usually a CT scan at 24 hours, ensures no new bleeding or swelling has occurred. Stroke recovery doesn't end in the hospital. Rehabilitation is essential and must begin within 24 to 48 hours if the patient is stable. The goal is to regain mobility, communication, self-care, and independence. A multidisciplinary rehab team includes physiotherapists for motor recovery and walking, occupational therapists for daily activity adaptation, speech-language pathologists for speech, swallowing, and cognitive therapy, and psychologists to manage depression and emotional trauma. Neuroplasticity, or the brain's ability to adapt, is the key to recovery, so early and intensive therapy is crucial. Long-term care involves managing risk factors like hypertension, diabetes, and atrial fibrillation, ensuring adherence to medications, nutritional support and safe swallowing, home modifications for safety, and support for caregivers who play a vital role. Many stroke survivors experience post-stroke depression, cognitive decline, or seizures. These must be addressed through follow-up and counseling. Rehabilitation is not just physical, it's a comprehensive process aiming to restore dignity and quality of life. Thank you for watching this detailed guide on stroke management. Always remember, in stroke, time is brain. Early recognition, rapid action, and evidence-based treatment can save lives and improve outcomes. Stay updated, stay prepared. This is EMT Essentials by Bilal, or empowering medical professionals. Subscribe for more emergency care content. See you in the next one.